Hello and welcome. I'm Steve Clemons, editor-at-large of The Hill. Thanks for joining us for our event today. It's called From Platform to Policy, the 2021 Healthcare Agenda. It's a virtual plunge into the future of healthcare in a new year, a new presidential administration, a new political climate. I'd like to thank our sponsor, Pharma, for their support of today's program. When it comes to issues of health, there's a lot on the minds of people across the country. One of the top concerns, of course, is the coronavirus pandemic and how this is all going to turn out. We're going to see a lot today on where we are in the pandemic, what we're doing with vaccines, how they're going to be distributed, and how we reach every corner of the country. While the pandemic has spurred innovation and an evolution in care, it's also highlighted the inequities in our healthcare infrastructure. Besides the coronavirus, recent polls have shown that the other top healthcare issues for patients include protecting coverage for pre-existing conditions, healthcare affordability, out-of-pocket costs, and the future of the Affordable Care Act. As a new Congress convenes in January, how can we ensure our health system is ready for the challenges not only of the president's on my mind, but also the future? What policies must be enacted to address racial disparities, income disparities, and how can the public and private sectors work together to promote inclusion and better healthcare outcomes, especially for underserved communities? We're going to be putting these questions and more in front of our fantastic lineup of speakers. But first, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag #TheHillHealth. Please get involved in the conversation, tweet a lot, react, send your questions in. We're broadcasting live. We'll be taking those questions throughout the program. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guest is one of the few physicians serving in Congress. He's a senior member of the Senate Health, Education, Labor, and Pension Committee. He has been one of the people right at the forefront of talking about the future of American healthcare policy, what we should be expecting for what we're paying. Senator Bill Cassidy, it's great to be with you again. You know, we've been around this circuit a couple of times. We're at a political inflection point, and I know in the times we've discussed this before, you've had concerns about getting Americans and getting patients into the center of and empowered in their healthcare trajectory. What do you think the big questions are, the big equities that we have to get right as we look into the next year?
If the goals of healthcare reform have always been, how do you lower costs, ensure access to as many people as possible, and make sure that you have the highest quality. Now, people always figure that you can only get two of the three. Our goal has to be to get all three. The Affordable Care Act, for example, did not really address cost, but so therefore we have cost as a driver of our national debt and deficit. You can control cost just by limiting access or decreasing quality. You don't want that either. So I think as we work going forward, I would argue that if you focus on aligning incentives, making the patient the center of the process, she's the reason for the care, not the excuse for the bill, and you align the financial and health incentives with the patient and the provider and the payer, then you can achieve all three. You focus upon better outcomes, you focus upon expanding access, but if you do it in a way which aligns incentives, then you will along the way decrease the cost, and that's where we need to be going forward.
You know, Senator, when you and I have discussed this in the past years, you know, what's I think not well understood by people out there is that there are a lot of players in the healthcare ecosystem. There are insurers, there are drug companies, there are PBMs, there are, you know, health providers in the hospitals and others. And there's been a revolution in a lot of this. But I think part of the hope had been as you move this system towards a wellness system and away from a fee-for-service system, there were going to be efficiencies that were created, that we would kind of move into a different place. The nation would become healthier. Do you find that naive? I mean, who are the black hats in this story and who are the white hats?
Well, I'm not sure it's naive. It's hopeful. But if you're speaking about much of our healthcare budget addressing lifestyle diseases, then you have to do something more than just say, okay, we're going to do value-based purchasing. You have to do something about the lifestyles that are incurring these illnesses. Some of them, the social determinants of disease, there's been a lot of attention. Stuart Butler, who formerly at the Heritage and then left, but he once said, If you compare the United States to Europe, they spend more on social determinants. We spend more on healthcare, but the sum is basically the same. You're going to spend it one way or the other. Probably we need a little bit more of a focus on those social determinants of disease. I do think there's a way to kind of bring the patient in on that. You can't do it without bringing the patient in. And if you do that, that will begin to impact. I think social determinants is the next frontier, if you will.
Now, you've been pounding hard for another iteration of a COVID relief package. You said it is vital. People's support is running out, that this is a dire situation. Are your colleagues hearing that message from you?
I think so. You know, there's somebody said this is a bifurcated recovery. There's some people who make their living on Zoom calls, and they're actually doing pretty well. And there's other people that make their living in the service industry, and oftentimes they're not doing well. So we need to make sure that we all do it well. Prior to the epidemic, we had wage growth that was disproportionately in the lower 2 quintiles of American income earners. We need to kind of recognize, well, that worked then. Hopefully we get back to that point. In the meantime, what do we help for those families that the breadwinner is now unemployed, or the folks who are food insecure, the folks who may be running out of rent money? If we can do that, get through the next few months, then we'll be back on a track where hopefully once more those bottom 2 quintiles are disproportionately doing better.
Okay, one of the things, I've tried, in various programs we've done with viewers is to convey to them what an unusual time this is, that when you look at viruses, diseases that have hit in large scale in the past, the rate at which Operation Warp Speed has come online. Now we see the distribution already of vaccines in the UK. Hopefully that happens here soon. You know healthcare and you know these issues, and I'd just love to hear where you think we've done really well and where you think we haven't in responding to COVID on the health science, the pharmaceutical side, and basically connecting on that front.
My gosh, I used to do vaccine trials, and it was amazing how long it would take to get the simplest data reviewed. Everything was done serially. So you would do the study, you would analyze the data, you would then go to FDA, who would approve the data. Then you would begin to set up your next protocol, which the FDA would approve. Then you would enroll on and on from phase 1, 2, and 3. Years to accomplish. And that was with things like hepatitis B, for which we had a pretty good idea of the immunology. Here we've gone from working out the genome of the virus to putting shots into someone's arm within 1 year. It is amazing. Now, Congress created this ability to do these things in parallel as opposed to serially. It had just never been utilized. I think it's a real credit to pharma, to the government, that we took these tools and we used them so well to get this vaccine, multiple vaccines out in such a period of time. The second part where we've not done well is almost inherent in medicine. My wife's a surgeon, and whenever she would always say, recommendations have changed. And she would say, of course they've changed. We know more now than we did 3 weeks ago. So initially people were told masks didn't help. And then they were told to wear a mask. We were told that the virus might be on a surface, so everybody's wiping down surfaces. Now we're told it may not be that much. I don't know where we are on aerosol virus infecting other people, but the point is there's been shifting recommendations, which has, I think, confused the American people, but is almost inherent in the way that scientists look at data. Always you could have done something better, but I certainly can understand why we didn't do as well as we could have.
Senator, you represent the state of Louisiana. I love Louisiana. I've been down there a lot, but it also happens to be one of the places in the country where this COVID virus has hit really, really tough. You have some of, I don't know how to put it, but lowest per one of the lowest per capita income in the state. So money and resources an issue. Communities of color that have not been, as densely networked in some of the healthcare systems. What do you think our responsibility is to bridge to some of those that have not, just to be blunt, received the same benefits that those who are networked in get?
So there's a lot of assumptions in what you're saying. By the way,
Right.
my background, I worked for 25 years in the Louisiana Charity Hospital System.
Sure.
And my primary mission was bringing healthcare to those who otherwise would not have. And Louisiana actually has a fairly good network of community health centers, FQHCs, and hospitals with a tradition of folks, even whatever their race, accessing care through emergency rooms, perhaps, or through the charity hospital system. We've also done the Medicaid expansion. And so, of course, that provides coverage of some sort to most people in our state,
Right.
who are not privately insured. So, so I think I would go back to, if you, so it's a difficult, it's easy to say, oh my gosh, it's a racial disparity, period, end of story, move on.
Right.
But if you peel back the onion a little bit, you see Medicaid expansion, for example, people had coverage. You do see a preponderance of disease of pre-existing conditions
Right.
in those who are more likely to die, regardless of race. So obesity, diabetes, hypertension, those are disproportionately in my state, and particularly among those who are in the lower socioeconomic, regardless of race. And those have been and if you take the people who have died have been in nursing homes, very elderly, and the other people who've died typically have had comorbidities.
Right.
Now, quite likely race plays a role here. But if you're going to do a regression analysis for the statisticians in the room, you're going to say what factor is being overweight, what factor is having diabetes, having hypertension, not having ready access to a primary care physician, what factor would be race. Now that, if we're really going to have an answer, we have to do that hard work and just not have some facile, this is the reason why.
Yeah.
It could be that we have a poor built environment where folks who would want to exercise cannot. Those folks happen to be disproportionately poor and African American. Because of that, they're more likely to have obesity, and because of that, more likely to die from a COVID infection should they be infected. But if we're really going to serve the patients whom we seek to serve, we have to do the hard work of that analysis to find those root causes if we're going to make a difference.
Senator, I really appreciate how you framed that and put that. I think it's such an important issue, the way you've kind of come in and explained it, because I do think there's some shortcuts that are taken. I appreciate that. Same thing when I discussed with Robert Redfield from the CDC, the Surgeon General, who's explained this a lot of way. But I think right now, when you look at how we're going to reach the corners of society, what's the equation towards health, it's a complex one that we have to do the heavy lifting on. So I appreciate that. We're taking questions from our audience, and we have a question for you from Robert Wolf. Robert?
My name is Robert Wolf. I'm an attorney at law. I'm admitted in New York and in Florida, and I am currently living in Florida. I was formerly the Associate General Counsel of New York Presbyterian Hospital, the Hospital of Cornell and Columbia. My question is this: how can the government lower drug prices while promoting discovery?
Thank you, Robert.
Great question, Robert. First,
it's the 900-pound question, really.
Yeah. So first, we have to recognize that a lot of the increase in drug prices is not necessarily related to the cost of drug development. We all know the example of the farmer bro who bought a drug, cornered the market, then began to raise the price dramatically. So if you look at the generics, that is one issue. Secondly, if you look at the biologics, there are biologics that are the originator drugs, and there are only a minority of drugs prescribed in the United States, but I think there might be a majority of the money we spend on drugs, or at least a significant minority of the drugs we spend. In Europe, they have allowed, by regulation basically, they've allowed biosimilars to compete with the innovator drug, and that puts a downward pressure on the innovator drug's price. In the United States, innovator drugs have managed to continue to keep the market, and biosimilars have had a poor uptake. Now, there are things you can do regulatorily that would encourage the more rapid adoption of biosimilars to drive down those costs. Keep in mind, some of these originator drugs have been on the market for over a decade, but they are still getting paid as if they are the only drug in town. And effectively they are, because the biosimilar is being discouraged in terms of its use. So I do think having a regulatory environment that promotes competition can achieve that which you've described. One more thing I will say, Robert. I have an article in Stat, which is probably from a year ago, but it's not behind the Stat paywall. You can pull it down. What do we do about genetic therapy? Think about it. If we come up with a gene therapy for sickle cell anemia, if you give it to the person on the first day of their life, you'll save over $1 million in healthcare costs by age 45. If you give it at age 45, you don't save a dime, because the patient already has the end organ damage of congestive heart failure, multiple strokes, necrosis of his hip joints, etc. So really timing is important. So how do you adjust the payment for a gene therapy relative to the value it brings to the patient? Now, we have some ideas in that Stat article, but I do think that technology, in terms of the innovation, we do save money with the appropriate use of gene therapy. That sickler not only avoids healthcare costs, that sickler is also paying into the tax system because he's gainfully employed. But we also have to figure out how to price it so that the innovation is awarded, but we don't waste money. And look at that Stat article, Robert. I'd be interested in your thoughts on it.
Just real finally, Senator, we're sitting and we're looking ahead. We're looking at 2021. Part of healthcare is healthcare policy. Part of healthcare policy are the people that are doing it. Xavier Becerra has been nominated by President-elect Biden to run HHS. Are you on board with that? Do you have concerns?
Well, I don't really know Mr. Becerra that well, but I'm not sure he has a healthcare background. It's kind of like putting a doctor in charge of the Defense Department. Why would I, as a doctor, be qualified in particular to be a head of the Defense Department? Why, as an Attorney General in particular, qualified to be a head of HHS? And I say that because Azar, I think, has done a great job in his role with Operation Warp Speed. Coming from a pharmaceutical background, he was able to prioritize and do an immediate analysis in his own mind of that which had to be done in order to execute the plan, as opposed to having to choose between advisors who knew more than he and trying to decide which to trust more. I think it's much better to have that native knowledge as opposed to having to decide, who to prioritize. Put differently, if you appoint a general, you want the general to have combat experience. If you appoint the leader of your largest healthcare agency in the United States government, I prefer somebody with healthcare experience.
Well, Senator Bill Cassidy, whenever we discuss the healthcare ecosystem, I learned from you. I think this isn't going to be a topic that goes away quickly, so I hope we'll have you back. Thank you so much for your time today.
Hey, thank you.